Welcome to Chapter 20, covering the hip. Anatomical characteristics of the hip region. So our hip is made up of the articulation between our pelvis and our femur. So our bony structures involved are going to be our pelvis and our femur. Hip joint characteristics and arthrokinematics. Characteristics of the hip joint. It is a ball and socket joint with 3 planes of motion, so it is a triaxial joint. The articular surfaces, there is a concave acetabulum on the pelvis with a convex femoral head that articulates. And there are 3 major ligaments that help to reinforce the joint capsule of the hip. We have our iliofemoral and our pubofemoral on the anterior aspect, and then our ischiofemoral ligament is on the posterior aspect. Arthrokinematics of the hip. You can review the kinesiology lecture over the hip joint to go over the specifics of this, but for what I need you to know for thorax right now is that when we have open chain motions of the femur, we have the convex surface moving on the concave, and mobilizations that we apply at the hip joint occur in the direction of the glide of the femur for open chain movements. So we're going to do anterior to posterior mobilizations to help increase hip flexion and internal rotation, because that would be the direction of the glide for the arthrokinematics of open chain motion for hip flexion and internal rotation. We'll do posterior to anterior mobilizations to increase hip extension and external rotation, and we'll do superior to inferior mobilizations to increase hip abduction. When the pelvis is moving, that is going to be our concave surface moving on our convex, and that's going to occur during our closed chain motions. Influence of the hip joint on balance and posture control. So we have to remember that we have hip strategies that are an important part of our balance and maintaining equilibrium. And joint pathologies, restricted motion, or muscle weakness can impair balance and postural control. Motions of the femur and muscle function. So we know that our hip is a triaxial joint, so it's going to have flexion, extension, ab and adduction, internal and external rotation. So if you look at page 739, table 20.1 breaks it down by the motion and the muscles that are involved. So if we look at hip flexion, we know that iliopsoas and rectus femoris are going to be our prime hip flexors, but we also get contributions from our TFL and our sartorius. It's important when we're looking at the prime movers listed in this table that we look at what other motions they cause, because we can understand where weakness is coming from when a compensation is demonstrated. So for example, we look at sartorius. It also abducts and externally rotates the hip as it flexes, and it also does flexion and internal rotation of the knee. But if we're looking specifically at the hip, sartorius is a hip flexor, a hip abductor, and a hip external rotator. So if in the process of a patient trying to achieve hip flexion, we see this compensatory abduction and external rotation, that might lead us to see that the patient is utilizing sartorius more than they're utilizing iliopsoas or rectus femoris. And so that tells us that we have weakness in one of those muscles and improper muscle firing. I would take a look at that table and be able to associate each of the movements of the hip with the prime movers and be able to identify compensations based on which muscles are supposed to be active or most active versus which ones may be active when we see these additional movements in place. Motions of the pelvis and muscle function. So anterior pelvic tilt, which again, when our pelvis tips anterior, we have our hip flexors and our lumbar extensors contribute, the force couple that contributes to that. Posterior pelvic tilt is going to be a posterior tilting of our pelvis backwards. Obviously, posterior means backwards, but the force couple involved in that is going to be our abdominals and our hip extensors. Pelvic shifting, clinically I wouldn't worry about this. This is talking about movement in the transverse plane in a standing position that puts the lumbar spine and hip in an extended position comparably, but we look at all the other movements of the pelvis more clinically, and so I wouldn't worry too much about pelvic shifting. Our lateral pelvic tilt is going to be either that hip hike or that hip drop that we see with either a compensatory hip hike with QL activation or a hip drop as a result of that Trendelenburg gait when we have contralateral glute med weakness. And then pelvic rotation is going to be that rotary movement that's named by the side that is forward that we see during gait. Our pelvifemoral motion is going to be how the pelvis moves on the femur, and so we look at this as a matter of flexion motion at the spine. And basically what we need to understand is that motion comes from the spine before it gets to the pelvis moving on the femur, and tension through the ligaments and approximation at the facet joints through the spine creates tension to allow for that movement to move down to the pelvis for any kind of anterior pelvic tilt that would occur with trunk flexion and movement of the pelvis on the femur at that point. The hip is where our trunk meets our lower extremity, and so movement and positioning of the hip affects movement and positioning of the knee and ankle, especially in weight-bearing positions. And so if we have decreased motion in one direction at the hip, that's going to affect the available motion at the knee and ankle and the position that those joints are in a standing weight-bearing position based on patient being able to achieve normal stance. Pathomechanics in the hip region, so decreased flexibility can cause postural changes, and the patient needs to be stretched to address that. The easiest to think about for the hip would be a patient with tight hip flexors. That's going to cause them to be in this anterior pelvic tilt, but it's also going to cause them to have this forward trunk lean, and so we can visibly see that a lot more evidently on how that's going to affect the joints. That's going to shift the center of gravity more anterior of the knee and ankle, so that's going to put more stress on the posterior capsule of the knee, and then also require greater engagement of the plantar flexors to maintain an upright stance to not let the collapse at the ankle into dorsiflexion. Muscle weakness at the hip can cause abnormal positioning at distal joints. It can also result in nerve compression because when muscles are weak, they become tight, and that decreases the space for nerves to travel. And it can also result in functional weakness where the patient is having limitations to their daily activities because they do not have sufficient strength. Hip muscle imbalances are going to be caused by muscle strength and length deficits. So remember that a muscle that is too short isn't going to be as strong as it can be, and a muscle that is too long isn't going to be as strong as it can be. And so when we have muscles that are either shortened or lengthened from their normal resting position, that's going to cause strength deficits. But it's also going to affect proprioception and neuromuscular control because now the inputs that those muscles receive are going to be altered, and that's going to be something that we need to work on with this patient population. This is often result in pain or overuse syndromes where there's compensatory shortening of one side of the joint and compensatory lengthening of a muscle on the other side of the joint, both contributing to proprioceptive deficits, both contributing to strength deficits, both contributing to muscle firing deficits. Asymmetrical leg length can also be a contributing factor to hip dysfunction. So we can see that with a unilateral short leg, which is just it happens to measure shorter than the other leg. We can also see this in presentations of either coxavalga or coxavera. So patients with coxavalga, that's going to be an increased angle of inclination, right? They're going to have a longer lower extremity on the affected side. So if you think about an increased angle of inclination, that's effectively making the femur longer, and so the affected extremity is going to be longer on that side. Comparing that with coxavera, that's going to be our decreased angle of inclination, and so that will effectively make the femur shorter and give them a shorter extremity on the affected side. Anteversion and retroversion occurring at the femur can also affect leg length. So a patient with an increased forward angle at the femoral head is going to have anteversion, and they'll have a shorter leg on the affected side because that's, again, going to effectively reduce the length of the femur. A patient with retroversion is going to effectively increase the length of the femur because there's less distance being lost with that rotation, and so that will create a longer lower extremity on the affected side with retroversion. The hip muscles play a huge role in gait. So if we see weakness in the hip flexors or loss of function in the hip flexors, we can see the patient use a posterior lurch to initiate gait so that they're using momentum by leaning the body backwards to send the leg forward. Tightness of the hip flexors can result in a decreased lordosis, a forward flex trunk, and or a shortened stride length. If we see hip extensor involvement, loss of strength in the hip extensors can result in a posterior lurch at foot contact, again trying to utilize the body's momentum to maintain stability at the joint instead of using the muscle activation. If we have tightness of the hip extensors, we can see increased forward rotation and increased external rotation or an IT band irritation. Loss of strength of our hip abductors can result in a Trendelenburg gait. So remember, that's going to be the contralateral side drops during swing phase. So if I am on my left leg for stance, I see a right hip drop during the swing phase. That's going to implicate my left glute med because my right side is dropping. Effect of musculoskeletal impairments on gait. So altered lower extremity alignment impacts gait mechanics. So if we have tightness that has impacted the joint alignment, then that's going to impact the lower extremity positioning and therefore affect our gait mechanics. Antalgic gait is going to be a decreased stance time on a painful side, and this is our stereotypical limping. You just think of somebody who does not want to spend time standing or weight bearing on a painful lower extremity, and that is the gait pattern that they're going to produce. The nerves that we can see involved at the hip are going to include our sciatic nerve, which is going to go to innervate our hamstrings, our obturator nerve, which is going to innervate our hip adductors, and our femoral nerve, which is going to innervate our hip flexors. Common sources of referred pain in the hip, so this is pain that is coming from the source somewhere else, but we are feeling or perceiving it in the hip. That's going to be our nerve roots or tissues originating from L1 to L3 or S1 to S2, and our lumbar, intervertebral, and sacroiliac joints. All of these can be irritated but refer pain to the hip where the patient reports hip pain. Jumping into management of hip disorders and surgeries. We'll kick it off with joint hypomobility, so this is going to be reduced movement, non-operative management for these patients. We're looking at related pathologies, so diagnoses that are going to be associated with joint hypomobility are going to include osteoarthritis, or degenerative joint disease, and post-mobilization hypomobility. Common impairments in these patients are going to include pain, stiffness, loss of range of motion, obviously because it's hypomobility, asymmetrical weight bearing, so they'll have a weight shift towards one side away from the affected extremity, and this can also result in postural changes. We can have progression to lumbar and knee involvement because it progresses up and down the kinematic chain. We can see impaired balance and postural control and decreased muscle strength and endurance as a result of the hypomobility. Common activity limitations and participation restrictions in this patient population are going to include activities that require prolonged weight bearing, like prolonged standing, whether that's something they have to do at home to be able to cook, or that's at work because they are a cashier and they need to be able to stand for their full 8-hour shift. But anything that requires prolonged weight bearing might be affected in this patient population. Transfers, stairs, squatting, and then daily activities like bathing, toileting, and dressing. And so in order to consider the functional movement that you need at your hip, I want you to take a minute to stop and think about what motions do we need at the hip to don and doff our shoes. I want you to write down what you think the answers are and bring that to class so that you can answer that question in class. During the protection phase for these patients, we're going to provide patient education on like the stresses that they experience at the joint based on different positions that they place themselves in. So whether that's a standing position or a seated position, how we can affect the alignment of the joint in each of those positions based on the hypomobility, and how to decrease those stresses and modify activities in order to decrease those stresses. We also want to teach them to do range of motion activities within that pain-free range of motion as much as possible at home so that we can help to restore mobility as quickly as possible. We want to help them with positioning in order to decrease their pain at rest, and teaching them how to utilize relative rest to help promote tissue healing. We want to decrease pain during weight-bearing activities, again, using modification as necessary during this phase of the game, and decrease the effects of stiffness and maintain their available motion by promoting those range of motion activities at home. As this patient progresses to the controlled motion and return to function phases, we're going to progressively increase joint play and soft tissue mobility, typically with our manual interventions, thinking things like joint mobilizations, passive range of motion into manual stretching activities. We want to improve joint tracking and pain-free motion, so we want to do active assistive and active range of motion activities through the pain-free range, progressively increasing that range of motion. But again, we're making sure that we have proper muscle firing for that joint tracking, and so that's why we might start with our active assisted range of motion. We want to improve muscle performance in the supporting muscles, so addressing not just the specific area of weakness, but also the surrounding musculature. A lot of times, the glute max, glute med, and rotator muscles are really important for standing tolerance, standing posture, and balance, and so those are important muscles to um, initiate strengthening and stabilization in as well. We want to promote activities for balance and aerobic capacity, and so these muscles, again, are going to be important for those things. And providing patient education on progressing range of motion, increasing tolerance to functional activities, and progressive return to whatever prior level of function they had. Moving along into surgeries of the hip. So arthroscopic procedures for the hip can include a chondroplasty, an acetabulum labral tear resection or repair, an osteoplasty and rim trimming, a capsular modification, or a ligamentum teres resection or repair. So a chondroplasty is going to address the articular cartilage at the ends of the articulating surface. The acetabular repair is going to address the labrum of the acetabulum. The osteoplasty and rim trimming is going to be going in to clean out the acetabulum. The capsular modification is going to address the joint capsule, and the ligamentum teres resection or repair. Remember, the ligamentum teres runs from the femoral head to the center of the acetabulum, and so that would be addressing that ligament. Post-operative management for these conditions is going to be found on pages 749 through 750, table 20.2 in your textbook. So if you want to take a look in there, it talks about your weight-bearing restrictions and how to initiate treatment. This is a good reference for these diagnoses, just to understand how to get them started. What I would be mindful of is that your weight-bearing restrictions for these are guidelines, but each of these patients should have a specific post-op protocol that their surgeon wants them to have this amount of weight-bearing for this amount of time. Like if you look at your chondroplasty, you can have toe touch weight-bearing for anywhere from 4 to 8 weeks. A labral repair, depending on whether they did a resection or repair, can be anywhere from 2 to 6 weeks of restricted weight bearing. And so these things are going to depend on the surgeon's preference as well. And so you want to make sure that you're referencing those things for your individual patient so that you make sure that you're following in line with your protocol. Total hip arthroplasties. Preoperative management. So like any of our arthroplasties, these patients are going to benefit from what I like to call prehab. So this is doing rehabilitation exercises prior to the surgery in order to improve muscle strength and muscle firing so they have better stability going into a surgical situation. Patients undergoing prehab prior to a total hip arthroplasty have statistically improved recovery timelines and achievement of prior level of function before onset of hip pain. There's a couple different ways that they can go about doing a THA. Different designs. Typically, your design is going to be relatively consistent with your rounded femoral head and your concave acetabular surface. But there's different materials that they can use, and that's going to be dependent on surgeon preference as well as individual patient factors like what the patient might be allergic to. You can also see a cemented versus a cementless fixation. Clinically, I don't know that I've treated either differently, but just know that that's something you can see documented in the chart. We can also approach a total hip arthroplasty from several different directions. Not listed in your textbook, but also is a directional approach that I have seen is a superior approach that does not have any specific hip precautions. But we have our posterior or our posterolateral approach, which is going to have our precautions of no hip flexion greater than 90 degrees, no internal rotation, and no adduction. We can see a direct lateral approach, an anterolateral approach. Our precautions for that are going to be avoid extension, avoid abduction, and less implicated but also sometimes considered is to avoid external rotation. We can also see a direct anterior approach or a trans-trochanteric approach. Make sure that you know your precautions that I discussed here that are your bolded approaches. Complications that can arise following a total hip arthroplasty, they can occur during the surgery. So our intraoperative complications can occur with malpositioning of the hardware, an intraoperative fracture while they're trying to place the prosthesis, vascular injury in the surgical approach, or nerve injury in the surgical approach. During early post-operative timeline, we can see complications that result from infection, a deep vein thrombosis, sensory or motor deficits, dislocation of the prosthesis, especially if they are non-compliant with their hip precautions, and a functional leg length discrepancy that is typically a result of muscle imbalances. Late complications that we can see are mechanical loosening of the joint for the prosthetic pieces or components, or heterotopic ossification. Following the total hip arthroplasty, early mobilization is strongly indicated for these patients, so we want to get them up and moving as quickly as possible, trying to do open chain motions, maybe in bed exercises, but also trying to get them walking as quickly as we can. Early ambulation has been seen to improve outcomes following total hip arthroplasty dramatically. We need to make sure that we are taking weight-bearing considerations into account. So most patients following a THA are going to be weight-bearing as tolerated, but we need to make sure that we check the chart and we are aware of what that patient's weight-bearing is, so that way we are promoting early mobilization, but within their weight-bearing limitations. Important patient education to provide can be found in box 20.5 on page 758, and that's going to go over the precautions based on the patient's approach for surgery. Also things like how to transfer, like we want to make sure that they have elevated surfaces to sit on at home so that nothing violates that hip flexion greater than 90-degree precaution. So we might educate them on elevated toilet seats or using something to elevate their bed post-operatively. We also want to educate them on transferring towards the non-surgical side so that they have greater stability and strength in their transfers. If they are progressing away from using an assistive device and they have hands free to carry things, we want to educate them on carrying things on their non-surgical side, so that way their center of gravity is shifted over towards their non-operative leg where they have greater strength and stability. In regards to turning, we want to teach them again to turn towards the non-affected side, the non-operative side, so that way we don't violate any of our hip precautions by pivoting on the surgical side. In positioning, we want to make sure that they are able to follow their precautions, so making sure that if they're in a seated position, their knees don't raise above their hips, and if they're in bed, they use an abductor wedge so that they do not let their legs or their hip cross into adduction. During the maximum protection phase for these patients, we want to provide all that patient education that we just discussed, and also patient education to reduce the risk of post-operative complications, like teaching them to get up and move safely, but also like muscle pumping exercises to prevent the risk or decrease the risk of DVT. Exercises and functional training should begin as soon as the patient is medically stable so that we can prevent vascular and pulmonary complications. We want to make sure that we prevent dislocation of the newly inserted prosthesis by complying with all of our precautions and promoting the muscular stability around the joint needed with isometric exercises. We need to make sure that the patient is independent in functional mobility before they can be discharged from their surgical setting, so they have to be able to get in and out of bed independently, stand up from the toilet or the edge of the bed, and be able to walk their household distances. We want to make sure that we maintain functional strength in the unaffected extremities so that they can be compensatory methods for the patient while the affected extremity heals. We want to prevent reflex inhibition and atrophy in the operated limb, so we want to make sure that we are limiting the effects of things such as pain inhibition or swelling inhibition, and helping the patient promote muscle firing, especially again utilizing isometric exercises to get that neural signal to the muscle and get the muscle awake and firing as needed. We want to regain active mobility and control with our range of motion exercises, promoting to stability through our basic functional needs like transfers, bed mobility, and short distance ambulation. And we want to prevent a flexion contracture in the hip because the patient's predisposition is to remain in a seated position or sitting up in bed and not getting up and moving, and so we need to make sure that we educate them on proper positioning so that they do not develop a hip flexion contracture during the recovery process. During the moderate protection phase, we want to regain strength and muscular endurance with a special emphasis on our hip abductors and extensors. We want to improve cardiopulmonary endurance in these patients, especially considering that the limitations that they were experiencing prior to having a total hip arthroplasty have likely resulted in some aerobic deconditioning. We want to restore range of motion within the patient's precautions. So again, pushing them to have as much mobility and flexibility as they can, as long as it is within the allowed ranges that the prosthesis isn't going to be at risk of dislocation. And we want to improve postural stability, balance, and gait. These patients are likely experiencing compensatory methods from before the surgery because, again, there are things that led up to needing a total hip arthroplasty. And so we want to make sure that we are addressing any of those compensations so that they have better joint alignment throughout all lower extremities and improved muscle firing and muscle length as they progress through the rehab process. During the minimum protection phase and return to full activity, we want to progress exercises that we were utilizing during the moderate protection phase towards their functional goals, integrating more of that functional demand. Table 20.4 on page 761 has some good ideas of what you can utilize during this phase of rehab. Knowledge check time. So a patient who underwent a right cemented total hip arthroplasty through a posterolateral conventional incision 3 to 4 weeks ago is permitted to do each of the following except A. Ambulation with an assistive device and weight bearing is tolerated on the right lower extremity. B. Flexion of the operated hip up to 90 degrees. C. Twist trunk over the planted right lower extremity while weight bearing. D. Standing active right lower extremity abduction. Pause now to think. And the answer is C. Twist the trunk over the planted right lower extremity while weight bearing. Remember, we want to educate our patients to turn away from the surgical side and turn towards the non-surgical side. Twisting the trunk over a planted right lower extremity would result in internal rotation at the right hip, a movement that is contraindicated following a posterolateral total hip arthroplasty. For a hemiarthroplasty of the hip, instead of replacing the whole joint where it's both sides, they just replace part of the joint, so one side. Post-operative management for these patients is going to include making sure that we avoid large compressive or shearing forces across the hip, and otherwise we're going to progress them similarly to our total hip arthroplasties because the surgeries are very similar. Hip fractures. So we can see hip fractures that happen within the capsule, and those are going to be our intracapsular fractures, and they're going to just happen within the femur proximal to the end of your joint capsule, and then your extracapsular fractures are going to be outside the joint capsule, so distal to that joint capsule. Fractures of the head of the femur, neck of the femur, those tend to be our intracapsular. Fractures to the shaft of the femur tend to be our extracapsular fractures. They can be managed non-operatively if they are stable, especially if surgery could pose any kind of medical complications for the patient. More often, hip fractures are going to be treated with an open reduction and internal fixation of the hip fracture, so that's an ORIF. If you take a look at box 20.8 on page 768 in your textbook, it talks about special considerations following ORIF, and that can primarily be related to where the fracture site has occurred and what muscles might be especially involved or implicated. Based on the fracture site and the attachment of the hardware. So if we, see a fracture at the greater trochanter, we might see more implication of our glute med. If we see a fracture at our lesser trochanter, we might see more implication of our iliopsoas. If we see a subtrochanteric fracture, we might see more implication of our glute max. And so depending on where the fracture occurs can help us understand which muscles are going to be involved and how that's more likely to present. Jumping back into non-operative management of the hip, these pathologies are going to be things that are managed without surgery that are likely due to bone or soft tissue injury in the structures surrounding the hip. So our first group here are going to be extra-articular musculotendinous impairments. So these are going to be things outside of the joint, typically related to our muscular system that are resulting in impairments in hip function and typically hip pain. So our tendinopathies and muscle strains that can occur at the hip, most commonly our adductors, flexors, and hamstrings are going to be involved. We can also see repetitive trauma injuries. These are most likely a result of a muscle imbalance at the hip that's causing increased strain on one of the tendons. I don't remember if it's listed on the next slide or not, but also included in this group are going to be our patients with bursitis. So bursitis is going to be an extra-articular muscular tendinous impairment. And remember that the bursa serve to decrease friction as the tendons run over bony prominences. And so when we have inflammation to the bursa, we can see inhibition of muscular function. And the location of the bursa can matter for, or the location of the bursa involvement can matter for the muscle involved. So like our trochanteric bursitis is going to be more associated with our hip abductors. Our psoas bursitis is going to be more associated with our hip flexors. Our ischiogluteal bursitis is going to be more associated with our hip extensors. Oh, look at that. I did include it. So jumping into those. So our trochanteric bursitis, these patients are going to demonstrate groin pain at rest that increases with weight bearing. So if they are seated, they're likely to have pain, but that as they go to stand, that pain is going to increase as they assume that weight-bearing position. They typically demonstrate a positive Trendelenburg sign, so when you ask them to have a single leg stance, they're unable to maintain a level pelvis. They will have pain that is aggravated by ambulation and stair climbing, and the TFL may be tight or overactive as a result of hip abductor muscle imbalances. A psoas bursitis is caused by excessive repetitive hip flexion. Remember, psoas fuses with iliacus to create iliopsoas, which is one of our hip flexors. And so when we have repetitive hip flexion, we have rubbing of that bursa, which can cause inflammation. And our ischiogluteal bursitis is demonstrated, these patients demonstrate pain with sitting because we tend to bear weight on our ischial tuberosities, which is part of where this bursa overlies. And this also may implicate the sciatic nerve because it travels close to the ischiogluteal bursa, and so inflammation there can cause compression of the sciatic nerve, which can cause those symptoms traveling the distribution of the sciatic nerve. Our intra-articular impairments, or things happening within the joint, can include our femoral acetabular impingement, or FAI, and this is where our labrum essentially is getting pinched between the femur and the acetabulum as the patient is being brought up into positions of increased hip flexion typically. Flexion with internal rotation can cause the greatest level of impingement. These patients typically have activity-dependent pain with complaints of mechanical symptoms such as a clicking in the anterior aspect of the hip. Common impairments in structure and function of these patients include gait deviations, an imbalance of flexibility and neuromuscular control, so they will need to be stretched and trained for muscle firing within the newly achieved range, and they'll have decreased muscular endurance as a result of reflex inhibition from the muscles being shut down from activating because of pain. During the protection phase for patients with femoral acetabular impingement, we want to provide patient education regarding avoiding the positions that cause the impingement and modifying activities that create that position. We want to help the patient control inflammation and promote healing to the aggravated structures. And so we will educate them on things like relative rest and use of modalities as needed. And we want to help develop support in related areas. A lot of times this develops as a result of tightness on one side, weakness on the other, and we need to work on strengthening and improving neuromuscular control on the side that we have weakness in, so that way as we're able to improve range of motion, we also improve stability. During the controlled motion phase, we want to develop a strong mobile scar and regain flexibility. We talked about seeing impingement of the labrum. We can also see impingement of different tendons with femoral acetabular impingement syndrome, including like our iliopsoas or our rectus. And so in those tendons, we can develop scarring that can be counterproductive to the alignment of muscle fibers that we need. And so if we suspect that there is scarring within the tendon as a result of this impingement, we want to make sure that we are utilizing our manual interventions like cross-friction massage to help mobilize that scar and promote proper tissue fiber alignment, so that way we have the ability to regain flexibility. We want to develop a balance in hip muscle length and strength. So again, where we have tightness, we need to stretch it, but we also are going to need to strengthen in that newly gained range. But we also have to assume weakness on the opposite side of the joint, and so we want to strengthen through full range on the opposite side of the joint and promote a better balance to where we have equal strength on both sides and we're not developing this unnatural pull on one side of the joint. We want to develop muscular and cardiopulmonary endurance. Remember that muscular endurance can be a contributing factor to developing femoral acetabular impingement, because if we don't have proper muscle strength and endurance, then we aren't going to have the ability to maintain that postural position that we need, and so then we get muscle tightening, because a tight muscle doesn't have to be a strong muscle, and it doesn't have to maintain endurance if it's tight. During our return to function phase, we're going to incorporate balance, neuromuscular control, and muscular endurance, and we're going to focus on function so that patients are able to restore function without pain or causing increased damage to tissues. On to Chapter 21, the knee. So technically we have two joints of the knee, and we're going to talk first here about the tibiofemoral joint. So this is the articulation of the femur with the tibia, with our convex femoral condyles articulating with our concave tibial plateau. I did type these in incorrectly, but I have fixed them here, so make sure that you make the same correction on your PowerPoint. Well, when we're looking at applying mobilizations, again, you're going to find some contradictory literature, and when we go over mobilizations in clinical procedures, the end result is what works for the patient is what you should do. But if we're following the arthrokinematics of the joint, if we're applying mobilizations to the tibia, which is going to be our concave surface, which rolls and glides in the same direction for whichever movement we're looking at, we want to apply a posterior to anterior mobilization to increase knee extension, because as the tibia moves from flexion to extension, we have that anterior roll and glide. So we want to promote movement from posterior to the anterior for increasing knee extension. Flip side of that, if we're mobilizing the tibia and we want to increase knee flexion, we want to provide an anterior to posterior mobilization of the tibia, because arthrokinematically that concave tibia would roll and glide posteriorly during knee flexion. So we want to apply a mobilization force anterior to posterior to increase the posterior movement of the tibia to increase knee flexion. If we are applying mobilizations to the femur for knee joint motion, an anterior to posterior mobilization is going to be utilized to increase knee extension. If we are again applying mobilizations to the femur, a posterior to anterior mobilization will help to increase knee flexion. Remember that we see the screw home mechanism at the tibiofemoral joint, and that is that axial rotation at terminal knee extension, where the knee locks into its position because of the larger medial femoral condyle. And our tibiofemoral alignment in most people is going to be approximately 5 degrees, the angle running down the shaft of the femur and the angle running through the shaft of the tibia. We have about a 5-degree offset in that. An increase in that angle is going to indicate that the patient has genu valgus, and a decrease in that angle is going to indicate that the patient has genu varum. Our other joint of the knee is going to be our patellofemoral joint. So we have the articulation of our patella with our femur, and we can often see mobilizations to this joint help improve range of motion as well. So looking at the arthrokinematics, the patella moves with the quadriceps tendon that is encased in, right? So we've got the quadriceps tendon above the patellar tendon below the patella, and in between is the patella encased in this same tendinous material that is only changed names by this bony landmark in the middle. So if we want to increase knee flexion, we're going to do superior to inferior mobilizations. So we'll hook our hand at the superior aspect of the patella and mobilize it in a downward direction. If we want to increase knee extension, we're going to do the opposite. So we'll do inferior to superior mobilizations. So we'll hook our hand underneath at the inferior pole of the patella, and we'll push it in an upward direction. Patellar compression is also something that occurs at the patellofemoral joint based on the position. So we have the greatest compression when the knee is flexed and the least compression when the knee is extended. Increased compressive forces during full knee flexion compared to full knee extension. And so if we're having a patient experience pain at the patellofemoral articulation, having them do exercises in a deep knee bend probably isn't going to be comfortable. We want to decrease that compressive force at the patellofemoral joint, and so we will start with exercises in a more extended knee position. Patellar alignment and patellar tracking are an important part of knee function. And so we need to look at how the patella moves during knee flexion and extension to ensure that there isn't a problem with knee function as a result of patellar dysfunction. There are both static and dynamic forces, so we have muscles and fascial structures and ligaments in place that help to keep the patella in its appropriate position, but those dynamic forces more specifically can cause greater imbalances. So patellar malalignment and tracking problems can be a result of an increased Q angle, and this typically requires vastus medialis strengthening in order to securely pull the patella more medially. We can also see patellar malalignment with muscle and fascial tightness, so an imbalanced firing between the vastus lateralis and the vastus medialis can result in a tracking problem. And so again, if we see inhibition of the vastus medialis, which is common with a more prone to take over vastus lateralis, we can see the patella being pulled more laterally during tracking activities for knee extension, and so again, we would need to train VMO firing. Plica formation within the knee can also impact patellar tracking, and so that would be thickening within the joint capsule, kind of plica's inhibitory structure, but getting down to what the specifics of plica are aren't important right now. But when that thickening of the tracking space causes disruptions in where the patella can go, then it can push the patella in the wrong direction. We can also see patellar tracking issues from hip muscle weakness. So a weak glute med and or piriformis causes increased stress on the knee and can also often result in a genu valgus collapse at the knee, which is then going to increase the Q angle and cause different muscle balance or imbalances on patellar tracking. There is very minimal knee stability provided by the bony architecture of the knee, right? We've got these really big round femoral condyles sitting on this really flat tibial plateau. The bones aren't designed to fit into each other very well to create this locking articular structure. And so we need to have more dynamic support around the knee in order to provide the stability that we need. Passive stability is provided to the knee through the ligaments, and so that's why our ACL, PCL, MCL, and LCL are important, and damage to those can result in functional deficits that prohibit stability, not even just pain limitations, but just stability with function. But because we only really have these four ligaments to keep, or these four static structures to keep this awkwardly bony, misshapen joint in place, we need a lot of dynamic stability at the knee. And granted, we do have some help from the meniscus, which helps to improve bony articulation, but really it's muscle balance at the knee that helps to give us the stability that we need for function. And so neuromuscular reeducation is an important component of improving knee stability and decreasing stress on ligamentous structures. If we have an imbalance between the quadriceps and the hamstrings, we're going to see the knee being pulled in the direction of the imbalance, and that's going to cause an inappropriate stress on either the ACL or the PCL, depending on the direction of pull, and so that's going to leave the patient more susceptible to injury and then requiring surgery. And so looking at those muscle balances can be really important, not only after injury, but also in injury prevention. The knee and gait. So muscle control of the knee and gait. Our quadriceps controls the amount of knee flexion at initial contact and the loading response, and then again during heel off and toe off. It also prevents excessive knee flexion during our initial swing and extends the knee during or towards mid stance. So our quad does a lot during gait at helping to not only get the knee extended as we need to progress it forward, but also preventing it from collapsing as we shift our body weight over top. Our hamstrings serves to control knee extension during terminal swing, so we're using momentum as that leg swings forward. Our hamstrings have to eccentrically contract to control the extension that we're getting so that we don't snap our knee forward. Our soleus limits the amount of knee flexion during pre-swing by controlling the forward movement of the tibia. So our soleus doesn't cross the knee, but it does contribute by influencing the amount of dorsiflexion that is experienced. So by the soleus acting by pulling the tibia back, it helps to limit the amount of knee flexion that happens. And our gastroc provides posterior support to the extended knee at the end of the loading response, just before pre-swing. This is a kind of visual representation to show you which muscles are activated when during the phases of gait. You guys will go over this a little bit more in depth with the gait lecture as far as understanding which muscles work when, but I thought it was a good visual to kind of pair with that last slide. The knee can also be impacted during gait if we have hip or ankle impairments. So a hip flexion contracture is going to prevent the knee from extending just before terminal stance. Length or strength imbalances to the muscles, like a tight TFL or glute max, can increase stress on the IT band and produce a lateral knee pain. Weak hip external rotators and abductors can cause excessive hip internal rotation with function like walking, leading to improper patellar tracking and patellofemoral pain syndrome. Overuse of the hamstrings can cause compensatory rectus femoris activation, resulting in anterior knee pain. Foot impairments like calcaneal valgus or varus can cause an increased Q angle or bowstringing of the patella, all of which are going to cause pain or dysfunction at the knee during gait. Referred pain and nerve injuries for the knee. Our major nerves that are subject to injury of the knee are going to be our common fibular or peroneal nerve, as it branches off from the sciatic nerve and wraps around the fibular head. It can be subject to compressive forces, especially if there's been any kind of casting, and so the common fibular nerve can be involved there. And the saphenous nerve can also be implicated at the knee. Common sources of referred pain, so remember pain that is coming from somewhere that isn't the knee, but we feel it in the knee, are going to be L3 vertebral level for the anterior aspect of the knee and S1, S2 for the posterior aspect of the knee. Moving on to management of knee disorders and surgeries. Non-operative management of joint hypomobility. So our common joint pathologies and associated impairments that we're going to think of for this patient population are going to be diagnoses of things like osteoarthritis, post-traumatic arthritis, rheumatoid arthritis, post-immobilization hypomobility, and our common activity limitations and participation restrictions for this patient population are going to be anything that involves moving the knee or typically weight bearing on the knee. During the protection phase, we want to control pain and protect the joint, so we're going to provide patient education on pain management techniques as well as promoting movement of the joint within a pain-free range and relative rest as needed, and utilizing functional adaptations to decrease stress and strain on the areas that are inhibiting movement. We want to maintain soft tissue and joint mobility with our manual interventions, whether that be range of motion and flexibility activities, soft tissue mobilization, or joint mobilizations. We can use grade 1 and 2 as PTAs. Remember, we can also utilize passive, active, and active assistive range of motion. And we want to maintain muscle function and prevent patellar adhesions. We utilize setting exercises, quad sets, again trying to ensure appropriate patellar tracking with that, and utilizing foot positioning to alter vastus lateralis versus vastus medialis firing as needed. If we turn the foot out, we get greater influence of vastus medialis firing, and so if we see a patient with a deficit there, we can target that. During the controlled motion and return to function phases, we're going to continue to provide patient education, really making sure that we emphasize the patient's understanding of improved dynamic stability to a joint will help decrease the stress and wear and tear on the bone, and so that's what's provocative of their pain in most of these instances, since most of them are arthritis related. We want to decrease pain from the mechanical stress, and again, doing so by making modifications as needed, but also promoting dynamic stability by strengthening the muscles around the joint and promoting proper muscle firing. We want to increase joint play and range of motion with our manual interventions as needed, improve muscle performance in supporting muscles, so not just the area of specific deficit, but looking at, hip musculature as well to see its involvement with the knee and providing the appropriate support, and improve cardiopulmonary endurance. Joint surgery and post-op management. So different procedures that can be done for repair and restoration of articular cartilage defects. Right now, I just really need you guys to be familiar with the names of them and understanding that they are utilized to repair articular cartilage defects, and that they're going to have a specific protocol that you will follow. Procedures in that category are going to include microfracture, osteochondral autograft transfer, mosaicplasty, autologous chondrocyte implantation, and osteochondral allograft transplant. Postoperative management is going to be just about following the protocol. The bigger the area that they had to repair, the more cautious rehab is going to progress. You can look at some considerations of things that will be included in the protocol on page 810, box 21.1. But overall, right now, they're going to have patient-specific variances, and so your biggest cue is to know that you need to look at what the patient is permitted to do. Total knee arthroplasty. So this is replacement of the entire joint. So that's going to be the femoral condyles and the tibial plateau surface. It is done typically when there's degradation of the bony surfaces that restricts patients' participation in daily activities. Complications that can occur following a total knee arthroplasty include infection, joint instability, polyethylene wear, component loosening, and deep vein thrombosis. Postoperative management for total knee arthroplasty is outlined pretty nicely on page 814 in your textbook, table 21.2. It takes you through each phase and kind of example interventions and what our goals of therapy are for each of those sections. So if you need a more expanded explanation than what we talk about here, that's a great place to look. Postoperatively, we want to look at considerations in regards to the patient's immobilization. Most of the time, these patients are not going to be immobilized, and if they are, it's not going to be for very long, but they may be placed in knee immobilizer early on, especially if they have quad weakness that they are trying to promote safety to keep the patient's knee from buckling. But early movement, early mobilization, early motion has been shown to benefit these patients most. Weight-bearing considerations, most of the time patients are going to be weight-bearing as tolerated following a total knee arthroplasty, but you just want to make sure that you check the chart and you follow the individual patient's considerations. Our exercise progression is going to be similar to other joint arthroplasties, where we want to protect early on but initiate muscle activation. Similar to the hip, we want to initiate ambulation early on with the knee, so that way we have better muscle firing with the weight-bearing activities. So during our maximum protection phase, our goal is to achieve 90 degrees of knee flexion and full extension. That's the range of motion that we're trying to get to. We want to regain quad strength in terminal knee extension, and that can be implemented or initiated with quad sets, and then we can do weight-bearing terminal knee extension exercises. We do not want to place a towel or a pillow under the patient's knee because we do not want them to get a knee flexion contracture that may keep them from getting that full extension or developing a knee extensor lag. So we need to make sure that we educate the patient on not keeping anything underneath of their knee so that they can get it completely straight following surgery. During our moderate protection phase, we want to increase the range of motion. Our goal is to push them to 110 degrees of knee flexion and maintain that full knee extension. So hopefully we were able to achieve that during the maximum protection phase, but if we didn't yet achieve full knee extension, we really need to push for it during this moderate protection phase. We want to regain lower extremity strength and muscular endurance, balance, cardiopulmonary endurance, and additional functional mobility. We will focus on functional tasks with weight-bearing and closed-chain exercises to promote muscle activation and muscle targeting with the proper stability needed for balance tasks. During the minimum protection and return to function phase, we want to incorporate proprioceptive and balance training. So all of our closed chain exercises during our moderate protection phase can help us be ready for kind of those single leg proprioceptive balance activities during our return to function. And we want to do function specific training so that the patient is able to perform activities safely and with as little modification as possible, but modification as needed for safety. Outcomes we are looking for in treating patients following a TKA are going to be pain relief, whether that's the pain that they were experiencing before the surgery or the post-operative pain. Our goal is to help give them resources to experience pain relief. We want to improve range of motion so that they have the functional range necessary. We want to improve strength and endurance of the muscles so that they have the joint stability necessary. And we want to promote physical function and activity level that they were previously at, as long as it is within compliance of what they're safely allowed to do following a TKA. So activity modifications might be required following a total knee because of needing to protect the prosthesis and the hardware. Box 21.4 on page 819 has a list of activities that are recommended with modification, and not recommended at all. I would pay special attention to those activities that are not recommended at all. They're going to primarily fall into those kind of repetitive, high-load activities that are going to just put a lot of wear and tear on the prosthesis, and so we want to make sure that we avoid those things following a TKA and that we educate our patients on avoiding those things following a TKA. So after that, knowledge check time. Which of the following exercises would not be recommended for a patient who has had a TKA 3 months ago? A, water aerobics, B, jogging, C, square dancing, D, stationary cycling. Pause now to read and think. And the answer is B, jogging. Jogging, along with running, sports that require jogging or running, and stair climbing machines are repetitive, high impact, high load activities for the knee. The peak load that occurs during these activities occurs during knee flexion, which can produce damaging forces on the prosthesis. We want to pay attention to the timeline in this question. Had this patient had the knee surgery 3 days ago, water aerobics might not have been the best intervention for them because without an occlusive dressing, that would be contraindicated because of an open surgical site. And so there's different levels of eliminating answer choices in here, but based on the options available, jogging would be the most contraindicated. Moving right along to patellofemoral dysfunction with non-operative management, we can look at a couple different factors contributing to patellofemoral dysfunction, and our local factors are going to include patellofemoral instability, and this can be caused by an abnormal Q angle, dysplastic trochlea, which is the space that the patella needs to track, patella alto, which is going to be a patella riding too high as a result of tight quadriceps tendon. We'll talk about that more in a second. A tight retinaculum or VMO insufficiency, where we have inhibition of the vastus medialis. Patellofemoral pain with malalignment or biomechanical dysfunction is going to be related to the patella positioning. So we have patella alto, which is going to be a high patella, and patella baja, which is going to be a low patella. And so they're named by their position, but the tissue that they affect matters. And so if this is our patella here, our little triangle-shaped patella, my quadriceps tendon is going to be above my patella, right? Running from my quad to encase my patella. My patellar tendon is going to be below my patella, running from my patella to my tibia. And so if I have shortening of my quadriceps tendon, I have patella alto because it's being pulled up. That's supposed to say PA. I know it does not look like it at all, but that is supposed to be a P and an A for patella alto. And then if I have tightening or shortening of my patellar tendon, that's going to pull my patella down. And so that's where I have patella bajo. Trying to make my P and my B look a little bit better. Hopefully that gives you a good visualization of those two. We can also see patellofemoral pain without malalignment, so the patella is sitting in the correct place, and that can be due to a soft tissue lesion, whether that's a hematoma or contusion within a muscle. We can have a tight retinaculum, so that's pulling the patella, but it's not necessarily causing it to track or position incorrectly. Or we can see patellochondromalacia, which is essentially breakdown of the cartilage on the posterior aspect of the patella, all of which can contribute to anterior knee pain experienced at the patellofemoral region. Proximal factors that can contribute to patellofemoral pain can include hip abductor weakness, hip extensor weakness, and hip external rotator weakness. Those are going to be the most commonly implicated muscle groups that cause improper mechanics or positioning at the knee that results in biomechanics that cause stresses on tissues that cause pain at the patellofemoral joint. Distal factors that can contribute to patellofemoral dysfunction can include improper foot alignment during weight bearing, and that's going to be our most common cause, typically causing an increased valgus at the knee. So again, the positioning of the knee causes increased biomechanical stresses that causes pain in the patient. Common impairments in this patient population are going to include pain, crepitus, range of motion deficits, weakness, poor joint positioning, so we could have altered joint positioning in a standing position, decreased muscle firing, balance limitations as a result of all of these things. Our activity limitations and participation restrictions, again, are going to be related more to things that require weight bearing and movement of the knee, especially knee extension because of compressive forces by the quad when um, given the patella being encased in the quadriceps into patellar tendon, but also deep knee flexion because of the increased compressive forces at the patellofemoral joint with that joint positioning. Management during the protection phase is going to be patient education regarding these painful positions and avoiding and adapting to manage, again, using pain control methods like ice as needed, utilizing non-stressful activities and relative rest as indicated, implementing gentle motion so that we are able to eliminate any edema that may be contributing to dysfunction, and also promoting normal muscle firing through the pain-free range of motion, and muscle setting exercises as quad inhibition is common and we need to make sure that we have proper quad firing. During our controlled motion and return to function phases, we want to continue to provide patient education regarding their progress and the need to improve dynamic stability while avoiding positions that increase pain, promoting range of motion through the pain-free ranges, and increasing muscle firing in the pain-free ranges as well. We want to increase flexibility of the restricting tissues, so patellar mobilizations might be indicated utilizing a medial glide for this population or medial tipping of the patella. We can also use patellar taping or kinesiotaping for the patella to help position it for appropriate tracking, especially if mechanical malalignment is the cause of the patellofemoral dysfunction. During controlled motion and return to function phases, we want to improve muscle performance and neuromuscular control utilizing things like proprioception and balance activities. We want to do non-weight bearing open chain exercises in a controlled eccentric fashion, and then we also want to do weight bearing closed chain exercises for that proprioceptive and balance input. And then we want to implement functional activities to restore function, ensure safety, and promote proper muscle firing through the performance of those functional activities. And as we go, we want to modify biomechanical stresses so that we decrease the potential reemergence of pain for this patient. If patellar instability is so great that they have to go in and do surgical intervention, then these are the surgeries that they may do for patellar instability, and that's about what I need you to understand of these surgeries right now. So we can have an MPFL repair or tightening, we can have an MPFL reconstruction, we can have a vastus medialis obliquus imbrication, or we can have a lateral retinacular release. Post-operatively for these patients, we're going to follow the protocol, and Table 21.3 in your textbook has a general outline of a protocol as far as things that might be considered in there for immobilization, weight-bearing exercises to initiate range of motion considerations. So you can take a look at that for reference, but again, you want to consider the individual patient's protocol because that's going to have surgeon-specific preferences and all of those things. Remember that immobilization and weight bearing is going to be patient specific, so make sure that you follow the protocol, but we want to promote mobility as quickly as possible as long as we have protected the appropriate structures. So again, follow the protocol if there is an immobilization period because of tightening of the patellar tendon, then we want to make sure that we're not pushing them into knee flexion and stretching that tissue before we want to. Exercise progression is going to be focused not just at the knee, but at the whole lower extremity, because much of patellofemoral dysfunction is thought to be a result of both proximal and distal causes, and so we want to progressively increase range of motion in a pain-free range while promoting muscle firing and muscle stability, but not just emphasizing knee function, but hip and ankle as well. Beyond the medial patellofemoral ligament repair, we can also have a distal realignment for repairing of the patellar instability. And this is where we have the patellar tendon and the tibial tubercle transferred to kind of realign and reposition the patella as appropriate. So procedures for this can include a tibial tubercle transfer, also known as an Elmsley-Trillat procedure, where they'll move it side to side, or depending on what location it needs to go into. There's an anteriorization or an elevation of the tibial tubercle, so if we have to move the patella up because we have a shortened patellar tendon, so that would be our patella baja, we might see an anteriorization. and a distal medialization of the patellar tendon, again, trying to change the tracking position of the patellar tendon. Postoperatively with these patients, we're going to again follow the protocol considering their immobilization and weight bearing as an individual patient by patient basis. Exercise progression for this patient population is typically going to be a little bit slower because we have more tissues to protect. Range of motion especially is going to have a slower rate of progression in this patient population, but we're going to again try to promote a restoration of function. Ligament injuries, we will start with the most commonly known, our ACL. So our ACL can be part of the unholy or terrible triad. The injury to the ACL, the MCL, and the medial meniscus make up our terrible triad. But our ACL is our anterior cruciate ligament. Injury to cause the terrible triad often occurs as a result of a lateral blow to the knee with a foot in a planted position. And so remember, our ACL prevents the anterior translation of the tibia on the femur. And so when we receive a lateral blow to the knee, that's typically going to displace the tibia anteriorly, causing disruption to the ACL. It's also going to cause a valgus stress at the knee, which is going to disrupt the MCL. And because the MCL attaches to the medial meniscus, it causes damage to the medial meniscus as well. ACL injuries are more common in the female population for a range of reasons, part of them being as a result of growth factors. And so we're looking at our teenage population here primarily when we talk about the gender differences related to neurological factors, because females go through more drastic growth spurts, especially at an earlier age. Before neuromuscular control can be developed, there's less dynamic stability provided at the knee in this population. Additionally, females tend to have less tight hamstrings, so increased flexibility in the hamstrings can put greater tension on the ACL to prevent that anterior translation of the tibia. If you think about where the hamstrings attach to the tibia, they're going to pull the tibia posterior, and so our hamstrings contribute to helping support the ACL and preventing posterior translation of the tibia. In male populations, they tend to have tighter hamstrings, which provide a static resistance, not even requiring the dynamic firing of the hamstrings to promote that anterior translation. And so this puts females at a greater risk of ACL tear. Our posterior cruciate ligament, or our PCL, it attaches from the anterior of the femur to the posterior of the tibia to prevent posterior translation of the tibia on the femur. It is most commonly injured as a result of an anterior blow to the tibia with a flexed knee, so something pushing the tibia backwards, often like a motor vehicle accident where there's a dashboard injury where the person's legs go into the dash and the tibia is displaced backwards, causing disruption of the PCL. We also have our medial collateral ligament, which spans the medial side from our femoral condyle to our tibia, and then we have damage to that when there's an excessive valgus load or that pushing into a medial direction at the joint at the knee, and so that's going to pull tension separating the medial side of the knee and stress that ligament. We can see injury to the lateral collateral ligament when we have an excessive varus load. So again, separating the lateral aspects of the knee is going to stress that ligament, and that would be a varus force that can cause injury. Common impairments in this population are going to be inflammation, quad inhibition, and joint instability. Remember, quad inhibition is when the quadriceps muscle is shut down as a result of pain and or swelling, and so there's decreased neural input and neuromuscular firing as a protective mechanism, and so we have to get the body to realize that it is safe to have the quad fire again. These patients will also have difficulty with weight-bearing activities that require knee stability, especially anything that requires any amount of agility. Conservative management would be patients that opt to not have surgery, so they are just being seen for rehab. During the maximum protection phase, we want to work to control swelling, provide patient education on safe activities to perform and how to prevent further injury to the damaged tissue. We want to perform quad setting exercises to overcome that quadriceps inhibition. Range of motion within tolerance, so staying in that pain-free range. Avoiding pivoting on the affected extremity, and non-weight-bearing stabilization exercises at the hip and trunk to promote proximal stability for the joint. As the patient progresses to the moderate protection phase, we want to improve joint mobility and protection by progressively increasing the demand load that we place on them with the activities that they can perform with the knee. We want to improve muscle performance, strength, and endurance by increasing the muscle balance surrounding the knee, addressing flexibility and strength and endurance. We want to address neuromuscular control through proprioceptive and balance training. We want to improve cardiopulmonary conditioning and progress them to functional training so that they can resume prior level activities. If the patient takes a non-conservative approach, so they opt to have surgery, there's different types of surgery that they can do based on which ligament is injured and what type of graft they do. Our intra-articular are going to be our ligaments within the joint capsule, and that's going to be our ACL and our PCL. Our extra-articular are going to be our ligaments outside of the joint capsule, and that's going to be our MCL and our LCL. We have different grafts that have different healing characteristics and where they come from. So an autograft is going to be a graft of the patient's own tissue, like their hamstrings or quadriceps tendon. An allograft is going to be a donor graft, so it's coming from another human being's tissue, and a synthetic graft is one that's been made. General considerations for rehab: so we want to expect to achieve restoration of joint stability and motion, pain-free and stable weight bearing, sufficient functional strength and endurance, and the ability to return to pre-injury participation. Indications for ACL surgery are going to be when the patient is unable to achieve joint stability necessary to perform in their prior level activities. There's the different approaches that they can do regarding where the graft has come from in the harvesting, and so where the graft is taken from and where it has been fixed is going to indicate what the patient can and cannot do. These are going to impact the patient's protocol, so it's important for you as the clinician to understand what type of ACL surgery the patient had so that you know that you're checking the protocol for the appropriate things. Complications that can happen with ACL injuries are outlined on page 842 in boxes 21.8 and 21.9. Post-operatively, we want to follow the protocol. Box 2110 on page 847 does a good job of giving specific considerations for different graft types and exercises that we want to avoid. But overall, one of the most specific ones that it talks about is avoiding open chain extension activities from 45 degrees to 0 degrees until at least 6 weeks, sometimes 12 weeks, depending on the graft site for patients with ACL. And that's, again, to not put undue stress on the ACL graft. And so that's a pretty consistent one to be familiar with. Immobilization and bracing, again, are going to be dependent upon the patient's protocol. Weight-bearing considerations are going to have the same thing. Exercise progression is going to start by protecting the injured tissues with neuromuscular re-ed and edema control type activities. Late phase training should include progressive resistance exercise with emphasis on eccentric training, advanced closed chain strengthening, advanced neuromuscular and balance control, advanced agility, plyometrics, and sport-specific activities. For the PCL, we're going to do the same thing in regards to following the protocol. Box 2113 on page 853 does a good job outlining specific considerations for PCL protocols, including limiting the number of repetitions into knee flexion to decrease the force applied or resisted by the PCL graft. Immobilization, protective bracing, and weight bearing are all going to be indicated by the patient's protocol. Exercise progression is similar to ACL progression with greater emphasis on hamstrings as opposed to quad. Meniscus tears can be managed operatively or non-operatively. We'll start with non-operative management first. Mechanisms of injury that typically cause meniscus tears are pivoting on a fixed foot, squatting, or high-force traumas. The medial meniscus is more commonly injured than the lateral meniscus because of its attachment to the MCL. Common impairments and activity limitations with meniscus injury include joint locking, swelling, quad inhibition, difficulty with weight bearing, and intermittent giving way or knee buckling. Management for this condition is going to include reduction of any joint obstruction with open and closed chain exercises to improve strength, endurance, and functional stability of the knee following surgery resolution if they had surgery. This is talking about non-operative management, but if there is a joint obstruction, then they're probably going to need surgery of some kind to remove the joint obstruction. But management in general, we see quad inhibition, so we need to make sure that we're working on muscle setting exercises for quad firing, improving dynamic stability around the knee, similar to any of the other conditions we've talked about here. Part of the reason that meniscus tears are not always repaired surgically is because of the vascularization of the meniscus. It does not have a great blood supply, and so indications for surgery, in order for it to be worth them doing surgery to the meniscus to try to repair and not just remove something that's obstructing the joint, would be that there has to be sufficient vascularization in the area of the tear for repair to occur. So there has to be enough blood flow for them to be able to surgically repair it, and then the body to do its thing for that repair to hold. They just go in typically arthroscopically and will put in sutures where the tear is, depending on the shape and extent of it. If it is unable to be repaired, then they will typically remove the portion of the meniscus that is causing any kind of joint obstruction. Complications that occur from surgical intervention for meniscus include damage to the saphenous or peroneal nerves and flexion contracture or extensor lag postoperatively. Postoperatively, again, we're going to follow the protocol. Depending on where the tear was and how it was repaired, those things are going to influence how much weight bearing the patient can do and how much knee flexion they are permitted to do. Box 2115 on page 857 takes you through a good look at those, breaking it down by different areas of repair. An important one to note from there is that if the patient's reporting any kind of clicking sensation in the knee following a meniscus repair, we want to make sure we report that to the supervising PT, and then from there up the chain to the surgeon as necessary, because that may indicate that the repair is not holding and that something is flapping to obstruct the joint space. Immobilization, protective bracing, and weight bearing, again, are going to follow the protocol. It is important to know that central zone repair has knee flexion limited to no more than 60 to 70 degrees for 8 weeks and typically requires bracing for 6 weeks. So central zone repairs require a lot of protection. We want to follow the protocol for these patients. Exercises are going to be to progress range of motion, strength, and function as appropriate per the protocol and the stage of healing. Remember, focusing on muscle firing and pain-free range of motion within the permitted range early on in order to work towards dynamic stability in a closed chain weight-bearing position later on. If that vascularization isn't sufficient and they do have to go and remove that part of the meniscus, that's going to be what we call a partial meniscectomy. Indications, like we talked about, are a tear to an avascular region, especially if it causes locking of the joint. Postoperatively, there's typically no immobilization or weight-bearing limitations because it's just been removed, so there's no repaired tissue to protect. The maximum and moderate protection phases, we want to do exercises to reduce atrophy and prevent contracture of the knee. We want to quickly progress to the moderate protection phase so that we are able to promote dynamic stability of the knee because we need greater muscular support given the loss of meniscus tissue, and progress as tolerated because, again, we are going to have greater chance of bony contact, which can increase the likelihood of pain if we don't have the appropriate dynamic stability. So we want to progress them as quickly as we can, but also within the patient's limitations. The minimum protection and return to function phases should have full pain-free and active knee range of motion, and a normal gait pattern should be achieved before progressing to high-demand exercises.